Hi guys. Today our topic of discussion is a very important topic, and many of you were having some or the other confusion about it. So today I'll be discussing the retinopathy of prematurity. Now start with the name itself. It is a retinopathy of prematurity. So this means those babies who are taking birth prematurely are the babies which are going to be affected, and these are the babies which are at the risk. Now, what do you mean by premature babies? So, we have got two criteria: the babies who are less than 34 weeks period of gestation, or the babies who are having the weight less than 1.7 kg. Now, I know initially the definition of ROP that was given was less than 1.5 kg as well as less than 32 weeks. But according to the Indian criteria, it is 1.7 kg, and we broadly take it as less than 34 weeks of gestation, because this is the time when the maturity comes in terms of the vasculature also, and in terms of the lung maturity also. The lung maturity, is due to the surfactant, and surfactant synthesis takes place roughly within 28 to 34 weeks. Now, if you see the retinal vasculature, right? Retinal vasculature, it starts from the optic disc, and up to the optic disc, it is reaching about 16 weeks. So it is up to the optic disc. Now from the optic disc to the nasal ora serrata, means nasal side, it is reaching 36 weeks. And the temporal side is even after the delivery, that is your 40 weeks, or roughly they say it is 1 month after the delivery. So this means those babies who are premature, less than 1.7 kgs or less than 34 weeks period of gestation, their retinal vasculature is not mature, it is immature. Now, if you are giving high concentration of oxygen to these babies, now what is the meaning of high concentration of oxygen? That means more than 30%. So, we should not give more than 30% of oxygen concentration to these babies. You are putting them in incubators. So, there are three risk factors: less than 1.7 kgs, less than 34 weeks, and giving the high concentration of oxygen. What happens? These babies are having lot of hypoxia. Why? Because their retina vasculature is not developed. And what happens due to hypoxia? The vascular endothelial growth factor released. Now here the cycle starts. When the vascular endothelial growth factor is released, there is lot of fibrovascular proliferation. This fibrovascular proliferation takes place especially behind the lens. Means if this is the retina and this is the lens, it is taking place in this area behind the lens. That's why it is also called as retrolental fibroplasia. This is the another name of the ROP. Retro means behind, lental means lens, and fibroplasia, retrolental fibroplasia. And you know that this tissue will be giving a whitish appearance. That is why it is also coming under the DD of leukocoria. So ROP is important because of its DD also, because it is one of the causes of leukocoria itself. Now we come to the stages of the ROP. Let's see the staging of the ROP. Now see this. I told you that the vasculature of the retina is not vascularized. It is not mature. It is immature, or there is some amount of avascularity in the retina. So stage 1 may we have a demarcation line. A demarcation line is there between the vascular retina and the avascular retina. Can you see? This is a, if this is visible to you, see this. this is a demarcation line kind of is formed between, on one side I have this avascular retina and on another side I have this vascular retina. So between them a line, just a line established. This is stage 1. Now stage 2 develops a ridge. What do you mean by ridge? Suppose this is a line. Now over this line it is something which is more thick has been developed. So this ridge becomes raised. Now line becomes raised as if you have put a line of bricks or a layer of bricks over it. So this thickened one is actually called as a ridge. So earlier it was just a demarcation line, now it becomes a ridge. Now this was your stage 2. One is your demarcation line, second is your ridge. Now what happens in stage 3? In the stage 3 we have got the fibrovascular proliferation. Can you see this area? I'll mark with the yellow color so that you can see it. See, this area was a ridge and here we also have this fibrovascular proliferation. So if I'll hide this color, then you will be able to see. Can you see this? So not only we have a ridge, we also have a lot of fibrovascular proliferation. Now what happens? This fibrovascular proliferation has a tractional effect. Means it can pull. It has a property of exerting the pressure. So what happens? It tries to contract. You always know that the fibrous tissue contracts. It contracts and it tends to pull the retina. So there will be what you call as retinal detachment. Yes, first it can be subtotal retinal detachment. That's why we have got stage 4 and 5 also. Or I can say 4A, 4B. So first is the line, then is the ridge, then is the ridge with fibrovascular proliferation, subtotal RD and then the total RD. In this way we have got 5 stages. See, the nomenclature is again very important in ROP because we have got stages also, we have got zones also, we have got clock hours, that is your extent also. So I think this is very, very clear to you. This was the staging. These were the stages, right? Now coming to the second thing. Second thing is the zones. What are the zones of the ROP? Second important thing is the zones. There are 3 zones in the ROP and they are with respect to the optic disc. Now let us see where is the optic disc and let's color it. This is your area of the optic disc. This is your optic disc and the macula, right? Now if you see here, this nasal side, this will be the nasal side where I have this optic disc and this is marked for the temporal side where I have the fovea or the macular area, right? Now concentric to this optic disc, I have got the zone 1, then I have zone 2 and farthest from this optic disc area we have zone 3. Now let us start with the zone 1. Now you know what is the distance of the fovea to the optic disc margin. If I take the normal distance, what should be the normal distance between the optic disc margin and the fovea? It is the 2 disc diameter, right? So I am taking twice this distance. So twice the distance between the fovea and the optic disc margin, I have taken twice. This becomes the radius of the zone 1. So this total, twice this becomes your zone 1. So it is concentric to the optic disc and the fovea and the radius of the zone 1 will be double the distance between the optic disc and the fovea. Okay, now come to the zone 2. Zone 2 mein we are going nasally up to the ora serrata. So let us take a different color here and we'll be marking the zone 2 here. See this area. Now this area which is going nasally, see this area is nasally. So this area will be your zone 2. The first area was totally concentric, but this area is going nasally up to the ora serrata. So we have got now this as the zone 1, and we have got this zone 2. Now, because the zone 2 is going nasally, you are left with the temporal area. Towards the temporal side, we have left with a crescent. So now we'll be trying to draw that crescent. Let us see where is that crescent. So here we have this crescent. Can you see this? This is this crescent, the third one, and this is your zone 3. So don't consider that all these zones are concentric, and it is typically 3 zones, but their area is different as well as their demarcation is also different. So we have got this zone 1, then we have got zone 2, and then we have zone 3. Let us see again. The optic disc to the fovea is 2 disc diameter. So twice the diameter, we have zone 1 concentric. Then we are going up to the nasal ora serrata, and then what is left temporal crescent, this green portion, this is called as zone 3. So we have stages, then we have zones. Now third is your extent. This is called as the extent. What do you mean by extent? Extent means how much of the area of one eyeball in terms of the retinal involvement, how much area is involved. So how will I tell that how much of this area is involved, or what is the extent of the involvement? That I actually will go with the clock hours. So see here, I've got 2 eyes here. This is your right eye and this is the left eye. Right eye and the left eye. Now what happens when you see the clock hours, you have to actually consider that the patient is sitting face to face with you. So you are like this and patient is like this. So this is your right eye and the patient's right eye will be on the opposite side. So see this, so this side is the nasal side and this side is the nasal side, and see we have got the optic disc on the nasal side. That's why I will say that this is right eye, because this is temporal and this is temporal. So temporal of the right eye will lie on the right side and temporal of left eye will lie on the left side. So macula areas will be on the temporal side, and the nasally we have the optic disc. So even if the nomenclature is not given the right eye and the left eye, you should be able to label them, that whether it is right eye, whether it is left eye. One thing. Now second thing. See, I have marked here the zones also. You can see the zones, zone 1, zone 2, zone 3. Here also zone 1, zone 2 and zone 3. Now how to tell the extent? We have to tell it in clock hours. Means I can divide it into different parts, like from 12 o'clock to 1 o'clock, 2 o'clock, 3 o'clock, 4 o'clock, 5 o'clock, 6 o'clock, and again 12 o'clock. How many clock hours are involved? So here we have 12 o'clock, 3 o'clock, 6 o'clock, 9 o'clock. Similarly here also 3 o'clock will lie on the nasal side, 12 o'clock, 3 o'clock, 6 o'clock and 9 o'clock. So either it can be involved from 12 to 1, 1 to 2, 2 to 3, 3 to 4. How many clock hours are involved, whether they are contiguous or they are discontiguous. So it will be told in this way. So what is ROP? What are the risk factors? What is the range of the development of the nasal vasculature? How much amount of oxygen can be deleterious and it can cause ROP? Then we have also seen what are the stages, what are the zones, as well as what is the extent. Now let's come to the another important thing. Now what is the concept of a threshold disease and a pre-threshold disease? What is the concept of threshold and pre-threshold? See, when it comes to the treatment, I have to see whether this disease is a threshold disease or it's a pre-threshold disease. Because if it's a threshold disease, I will have to treat it. If it's a pre-threshold disease, then I have to do the screening as well as the continuous follow-up I have to do. So because you know that when the disease is actually pre-threshold, it is high risk, and any time it can go to threshold, and therefore it may need treatment anytime. So you have to keep this patient in continuous follow-up. Now, what is threshold first of all? If the person is having the extent, at first I'm talking about the extent, continuous 5 clock hours are involved. Continuous means it may be starting from 12. So 12 to 1, 1 to 2, 2 to 3, 3 to 4, 4 to 5. Continuous 5, or they may be discontiguous, but then I require 8 because we have got 12 clock hours. Okay, so out of these, either 5 contiguous or 8 non-contiguous clock hours. Now which stage? Stage I need advanced, right? So stage 3. Stage 3, 5 contiguous, or I require 8 non-contiguous. And which zone? Which zone? It should be close to the optic disc. So either zone 1 or zone 2, right? Along with this, I should also have the plus disease, something which is extra to this also, plus disease. Now, what is this plus disease? Plus disease is something like this. We have got, what is this? The arteries which are tortuous, veins which are engorged, tortuous arteries. Now, I have a mnemonic for this. The mnemonic is tortuous arteries, engorged veins. TAVE, TAVE. Tortuous arteries, engorged veins. If it is lying at least in 2 quadrants, you are getting tortuous arteries and engorged veins. I have 5 contiguous areas or 8 non-contiguous areas in stage 3, zone 1 or 2, and I have tortuous arteries and engorged veins also. Then I will say that this is a threshold disease and I need to treat it. How will I treat it? There was avascularity. Due to that avascularity, there was lot of VEGF, lot of obliteration. So what I will do, I will coagulate these vessels. So what I will do, laser photocoagulation. We are doing the laser photocoagulation of the avascular retina up to the ora serrata. And which laser I will use? The diode laser. And which laser I will use? The diode laser I will use. Okay, now which are the stages which are pre-threshold? They should be under close observation because they may require treatment anytime. They can go to the threshold disease. So this is number 1, the zone 1, which are very, very close to the optic disc. If we are having zone 1 also and I am having the plus disease also, if I am having zone 1 also, I am having plus disease also, then any stage is a pre-threshold disease. In the zone 1 plus disease, any stage. But if I have zone 1 and stage 3, then even I don't require the plus disease. Zone 1, stage 3, again pre-threshold. Then third criteria. Now this is 2 plus 2. 2 plus 2 is an easy way of remembering this. 2 means zone 2, plus means plus disease, and second 2 is stage 2. So 2 plus 2 is also a pre-threshold disease. Zone 1, any stage. If it is 1 plus, then any stage, and if it is 1 plus stage 3, then I don't require the plus. So this is a way of recalling what is pre-threshold and what is threshold. Now coming to a very, very important criteria, and that is the screening. So let's see the screening of these babies, how to do the screening, when to do the screening. So let's see this. First of all, what to use for the screening. So we have to use the indirect ophthalmoscope because I want to see the periphery or the ora serrata. So I will use the indirect ophthalmoscope. Now when should I screen? So what I do, I divide these babies into 2 parts. Babies having less than 28 weeks period of gestation and babies who are born more than 28 weeks of period of gestation. So smaller the babies, earlier you have to go less than, so within 2 weeks, those babies who are less than 28 weeks, within 2 weeks we will examine them. Those babies who are more than 28 weeks period of gestation, now we have 2 categories, less than 1.7 kg, more than 1.7 kg. Less than 1.7 kg will be examined within 3 weeks, and more than 1.7 kg will be examined within 4 weeks. So within 2 weeks of birth, within 3 weeks of birth, and within 4 weeks of birth. So they say that usually with the help of indirect ophthalmoscopy, examine these babies any time between 2 to 4 weeks. Ideally, you should do the examination within 2 to 4 weeks of the birth. Some books also say that the first examination, if you talk about the first examination, then they say that if the baby is very, very small, you can go 6 to 7 weeks after the birth. Like for example, if I say baby taking birth at 27 weeks, right? So what can I do? Either I can go up to 6 or 7 weeks, that is 33 to 34 weeks it is, or we can take straight forward 34 weeks. Either 6 to 7 weeks after birth, or I can take 34 weeks, whichever is earlier. Because earlier the screening, better it is. So because there are different kind of questions formed on this ROP screening, therefore you have to take these different criteria in mind, because one criteria I have seen does not fit to solve all the questions. So I have tried to give you the lines from the different data so that you can sum up them. Less than 28 weeks of the baby means within 2 weeks. Then more than 28 but less than 1.7, 3 weeks. More than 28, more than 1.7 is 4. So it is 2 to 4 weeks, or it is 34 weeks. So 34 weeks, maybe if they are asking you the range, it can be 32 to 36 weeks, because this is the time when your nasal vessels are growing. And if they are asking you after birth, it can be even 6 to 7 weeks after the birth. So quick recap, the ROP is the retinopathy of prematurity, less than 1.7 kg, less than 34 weeks period of gestation, with high concentration of oxygen. Now this immature retinal vasculature gets obliterated, there is hypoxia, vascular endothelial growth factor is released, leading to immense fibrovascular proliferation. That's why it is also called as retrolental fibroplasia, and giving a DD of leukocoria. We have stages, we have got zones, we have got extent. Stages was a demarcation line, there was a ridge with fibrovascular proliferation, then the subtotal RD, total RD. Then we were having the zones, there were 3 zones. The zone 1, twice the diameter between the optic disc and the foveola, concentrically around the optic disc. Zone 2, nasally up to the ora serrata. Zone 3, residual crescent on the temporal side. Then we have the extent. Extent is in the terms of clock hours. Now we have threshold disease, pre-threshold disease. Threshold disease needs early treatment, urgent intervention. Pre-threshold, close monitoring, keep on monitoring. Whenever you feel like it's going into threshold, then you have to treat it. What you have to do? Laser photocoagulation you have to do. Obviously fibrovascular proliferation may you have to do the laser photocoagulation, for which we are using the diode laser. But if it's going even in the detachment areas, then you have to do the surgeries, vitrectomies have to be done. And then finally we have the screening within 2 weeks, 3 weeks and 4 weeks by the indirect ophthalmoscopy. So I hope you have got this, and will be coming with more such topics. If you like the video, then please do like it, share it and subscribe to my YouTube channel. Thank you. Bye-bye.